After listening to today, I'm not sure a DPhil in ethics is harder than what I've heard. First thing, just want to say thank you very much for inviting me along to speak today. It's really nice to be here. Obviously, it's different to the rest of the talks, and partly in its subject matter, but also in terms of the idea. So the idea is for it to be a bit more interactive than some of the talks throughout. So I've tried to deal with that in two ways. One is that I'm very happy to be interrupted if people want to ask questions or say things through the talk. The other is that I've cut down the number of slides, so I've got about 15 slides, so there'll be plenty of time hopefully for discussion afterwards, but obviously not if you interrupt a lot. But I'm very happy for that to happen. One thing that's perhaps worth saying is that although my background's in ethics, your experience of ethics may not link up very neatly with the way I think about ethics. So most of you, I guess, would have thought about ethics, although the previous talk was a very good example of differences. But most of you will have encountered ethics, I imagine, as sort of getting your research through ethics committees. So the idea of the governance of research, or a hurdle, an obstacle potentially to you doing research. The way I think about research ethics is that it's about working in partnership with scientists and with health professionals to try to identify and address the practical ethical problems that you face in your work in order to make it successful. So many of the scientists that I've worked with, and I'm sure many of you in this room, given your area of interest, will have come across ethical issues in their day-to-day work that weren't identified by an ethics committee, the ones that you've worried about and struggle with in your work, such as, for example, the animal ethics we've just heard about. So what's the best way to deal with that problem in the context of my research? How can I feel comfortable with the research that I'm doing? So I'm interested in that way of thinking about ethics. Ethics is a contributory factor to successful science. That's perhaps worth saying at the outset. Now, obviously, I can't talk about all of the ethical issues that arise in reproductive medicine, because there are a lot of them. It's an area where there's a lot of ethical controversy and a lot of ethical discussion, and we've heard many of those issues raised during the day today. Mitochondrial donation is one that's been mentioned, and it's interesting how much is attached to the idea of donation as opposed to transfer. So I noticed the person who spoke about that in the day was cautious about using the idea of donation because that raises issues about three-parent children and that kind of thing. So the terminology itself has ethical connotations. Gene editing, and particularly where that relates to germline modification, is another area where there's been a lot of work on ethics, and there's going to be an incredible need for more work in the future. Non-invasive prenatal testing and the implications of that, I'll come back to that later. Research on embryos as a general area for thinking about ethics, and the recent discussion in the UK about whether the 14-day rule needs to be changed, whether we need to allow a longer period for research on embryos, or whether it should stay as it is. That's a topic for debate at the moment. And very much broadly, the whole range of ethical issues that arise in assisted reproduction and research related to that, and we've heard much about that today. Issues related to prenatal diagnosis, pre-implantation genetic diagnosis, and a whole range of others that wouldn't fit on this slide. What I've taken as my focus, just to get us going, is the bringing together of reproductive research related to prenatal testing and genomics, because tomorrow is about genomics, so it's sort of a bit of a bridge between the 2 days. And I want to introduce some areas for discussion. And I thought one way of doing this would be just to give you a case study. This is a project that I'm personally involved in. As I said, one of the things I try to do is to try to do ethics close to practice. So I'm a PI on this project, which is called Prenatal Assessment of Genomes and Exomes, and it's a collaboration between the Sanger Institute, two research units in particular, one in Birmingham, one at Great Ormond Street, but also it's a collaboration between all the clinical genetics units in the country and many obstetric and gynecology departments. So it's a big national collaboration. And the starting point for the project is that in many cases where a structural abnormality is identified in pregnancy, it's not possible to provide the woman or the couple with a diagnosis or with an explanation of why that is. And the potential is, the idea for the project is there's potential for genomic approaches to offer improved rates of diagnosis, better patient care, and more informed reproductive decision making. And yep. No, it's good.
So are these unselected trios, or are the trios that are involved in this study sort of pre-selected based on something?
Yeah, so they've gone through a number of they're people who've, I'm not a scientist or a clinician, so excuse the kind of blunt. Basically, these are people who've had a problem identified in their pregnancy at a normal reproductive medicine unit or clinical genetics unit, and the usual kind of tests are being done or are about to be done. So amniocentesis, so for example, and they've been identified as particularly problematic cases to understand. And so that's how they've ended up here. They've been referred to Great Ormond Street or Birmingham and then to Sanger. And so the idea is through looking at trios to develop better techniques for diagnosis. And the project has had quite a lot of success with that. There was a paper published in Nature a couple of weeks ago, I think, which showed some of their results. And one of the things that's potentially interesting from an ethical point of view is the project has made a decision primarily because of the time it takes, but also it was an in-principle decision not to feed back the results of the genomic testing during the current pregnancy, that the information would be fed back after the pregnancy, which could, of course, still be relevant to future pregnancies and future reproductive decisions. And partly the reason was because it might not be possible to do that, but there was also a view that it wasn't appropriate because of the potential blurring of the clinical and research boundary that we heard about earlier. And of course, data from the project is shared with the wider scientific community to improve research in this area. So against that background, I just thought I would map out some areas that I think are ethically interesting in the use of genomics in reproductive medicine. And I'll start off in a fairly high level. And one of the things that I think is particularly interesting in research that we heard about today is the way in which the relationship it involves between research and clinical practice. So historically, for a number of reasons, we've tried to keep those two domains of activity separate. Some of those reasons are to do with the intentions, generating knowledge as opposed to improving the care of this particular patient. But some of them for ethical reasons. Worries, for example, that people might misunderstand research as a therapeutic intervention, what's called the therapeutic misconception. But that is no longer sustainable. Increasingly research and clinical practice are now done together. And that raises important questions, I think, about ethics, but it also in particular raises important questions about the responsibilities of the people involved in those processes. So in the past, it was reasonable for a researcher to say, I do research, I'm not responsible for their care of this patient. However, in a project like the PAGE project, for example, where we're doing research during a period which is relevant to the patient's care, for example, reproductive decision making, where the information generated through the research is likely to be of clinical relevance, at least in some cases, it seems less likely less justified to sustain that relationship. So where's the line going to be drawn between responsibilities of a clinical nature, and how do we do that? So we heard about the Belgian approach, which is to draw a line. And one approach that's also been proposed is a kind of technological solution, which is we just don't reveal that kind of data. And it seems to me that those are possible solutions, but they're not morally neutral. So putting a wall between research and clinical practice is itself a moral choice. It's a choice that certain information is not going to be fed back.
I have to comment. It's interactive, right?
Yeah. Yeah, it's meant to be. No, it's good. So I'm not saying this.
To me,
yeah.
The problem is indeed that it wasn't. At least that clinical implementation was not a research project anymore. So it's a clinical decision not to communicate everything, which is not, so at that point in time, it was not anymore a research project.
So in your that's right, in your case. But there are cases and other projects I've been involved in where a decision has been made, for example, to try to filter the data, so as a sort of technological solution, or to not feed back data from the research lab to the clinical team. And that raises all sorts of issues. It raises issues in current medical practice too, where staff in research labs feel uncomfortable holding data that could be clinically useful that's not going to be fed back. So it's a complex area.
I do feel another discussion because there's for example, with NIPT, we implement it, we do the genome wide, and then the question is, because you have that information, it's clinical, but where is the line of, okay, this is still experimental in a clinical setting, or is this clinical? And you could say, okay, you need to do a validation study and so forth in terms of sizes of lesions, and so I showed the one case where we did report back. There's a big discussion in the community, maybe you come back on that, whether that should be done at all because of the risk of false positives. But then in our environment, we don't have any false positives.
Yeah.
So that's another one. Anyway, sorry.
No, I want you to interrupt. It's good. I think there's a genuine debate here. I think there's an argument, for example, to say we need a degree of paternalism here. Paternalism being professional judgment about what the appropriate information is to feedback and how that can be managed. There's also an argument here about resources, about time, about management. You know, there are a whole range of things in healthcare that we aren't currently able to provide because we don't have time. So, you know, do we want to clog things up further? But there are also arguments on the other end to do with patient autonomy, to do with patient-centeredness, which are saying that, you know, people ought to be able to have the information that they want. So, for example, the 100,000 Genomes project, which I'm also involved in, if people want their data, they can have it. You know, there's maybe costs associated with that, but there's a whole range of different views here.
Would you think that the distinction line goes in the interpretation of the data and its sort of robustness in a sense? So just hypothetically, if I'm doing a research project, I want my data to be highest possible standards and integrity, of course. But since I'm pushing a question forward that I don't have any answers to, and probably hopefully nobody else, there is such a level of uncertainty there where we were just chatting about it in the break. Like if you're going to push something out in the clinic and actually inform somebody to make life choices based on the data, you can't, like the confidence intervals around what's the truth in a non-Trump truth way has to be a little bit more narrow somehow. And I think that sort of, for me, would drive the different, I wouldn't say ethical standards, but ethical incentive, if that makes sense. Do you know what I mean? It's not that I have lower ethical standards than somebody in the clinic. It's just that if I'm going to advise somebody to abort a fetus, you know, maybe after 10 times of IVF and all the savings, and I would probably want to be even more certain.
Yeah. Absolutely. So I just think there's a need for us to have some conversations about clinical practice that are going to be quite uncomfortable. So we've been moving towards, for many years, since the 70s or so, we've been moving towards an idea that patient-centeredness is that we should be non-directive, patient-centered. We should be providing as much information as we can. I think we're in a place now, we're approaching a place where we're going to have to make some decisions about which require us health professionals and researchers to take some responsibility for those kind of questions, and that's going to be difficult. But I don't think it's going to be based on a separation. My instinct is not going to be based on a separation of research and clinical practice, because those two things are going to become much more closely related. It's going to be a question about principles relating to information, to doctor-patient relationship, those kind of questions, I think. You're going to say something?
I suppose I was just going to make a comment, which is working in reproductive medicine. We've moved so far from the paternalistic view to the consumer view that actually I think that's where we've got to start taking a stand and saying, actually it's not right for me to offer you this, and I'm not going to do that. But it's so far from kind of the shift from where we've been, which is that actually it was time to give patients the information and the choices. But I feel deeply uncomfortable with that in very much of what is presented to patients as options in IVF treatment.
Well, I've spent 15 or so, maybe more years sitting in clinical genetics units and you know, that sort of. And one of the things that's striking to me is there is a degree of that. Clinical genetics talks in a very patient-centered way. It's all about autonomy. It's about non-directiveness. But actually, if you look at practice, for example, around how people are discouraged from getting access to prenatal testing for minor conditions, for example, there is already a degree of paternalism in those practices, which may not be inappropriate, but it's not explicit at the moment. So I think it's having that explicit conversation that's going to be difficult, to be honest. Yeah.
So there is the other spectrum of that is I do obesity research, and I'm certain everyone is, and I apologize if somebody's a major stockholder. This is my personal opinion. But today, when everybody can get access to the genome genotype, and people do quite wide interpretation, so there's a nutriogenomics sort of field that is sort of budding, and they start to genotype people and give them advice. and it's based on absolutely no solid data, no analyses, and it's also in the paternalistic view in the sense a duty, I feel, to help people understand the data and interpret it, because the power is in the interpretation and the integrity of the data.
Yeah.
But if you can't interpret the data and somebody tells you, oh, you know, your homozygous for, you know, the IRS5 gene, so you shouldn't eat any gluten.
Yeah.
And, you know, people spend $200 to get that information. And then, you know, placebo is a strong effect, and they would go around and feel great for at least 6 months afterwards. but there is, you know, and that's sort of maybe a more benign version of it, but you could easily imagine also in reproductive traits, where you could start to charge people quite lots of money for something that has no valid.
Yeah. So I think commercialization is an important issue. I'll come back to that later in relation to NIPT, but it's across the piece that's I mean, one of the things I think it's important, I can feel a bit, this discussion is one which potentially suggests there are lots of ethical issues and not much in the way of guidance, direction. I think it's important to say something about that, because my experience has been that is often perceived by scientists as a threat, as it were, as a problem. Well, what's the point? But actually, I think there's an opportunity here for you as a scientific community to set the agenda about what good practice ought to look like. So some of the work that I've done, for example, previously with the Wellcome Trust Case Control Consortium and with MalariaGen, in the early days of data sharing kind of was contributed to the discussion about managed approaches to data sharing, how you can have data access committees, for example, which support science by being relatively cautious and seen as careful. And I think potentially a scientific community can develop a model of what counts as good practice, say what you think about that, and that is actually quite influential if it's a group like this. An important thing to say about ethics in all areas is that it's another perception about ethics is that it's about saying that stuff's wrong, you shouldn't be doing stuff. But there are also it's important to recognize there are strong ethical arguments for doing things. And one of the strongest ethical arguments in this space is the fact that, for example, in the PAGE study, there are many women who have problems with their pregnancy and are not provided with care or with a diagnosis because the information isn't good enough. So there are strong ethical arguments in favor of the kind of research that you're doing. And some of that at least is based on benefits. So better understanding, increased rates of diagnosis, more informed reproductive choices, better outcomes in pregnancy, better treatments and so on. So there's a whole range of ethical arguments. And of course those need to be assessed and judged in the context of potential harms. So worries, for example, about germline modification and that's the unpredictability associated with that, the potential risks of therapies. So for example, gene editing, how can we ensure that any approaches that we adopt are ones where we've thought carefully about safety. Mitochondrial transfer is another example where we heard about the evidence of safety earlier. So ethics is not just about principles, it's also about facts. So here's an area where we can perhaps do some empirical work to look at the risks and benefits, and that might help inform those discussions. One of the issues that we've heard a lot about today, and it comes up all the time in the area of genomics, is what should we do about the findings that we've got? So some of those findings are ones that relate directly to the condition we're interested in, and some of them are incidental. And often we talk about incidental findings as if they're problematic, and the ones relating to the disease are not problematic. And you in this room know that's not the case. There's huge amounts of uncertainty, even if you're just looking at the findings that relate to the condition. So how do you feed those back? What do you feed back? What don't you feed back? Are questions that don't only apply to incidental or unexpected findings. So it's important to remember that. But the world has changed, I think, in the last 10 years. When I was involved in UK Biobank in the early days, when I've been involved in the DDD project, it was reasonably acceptable to say we're a research group, we're going to minimize the amount of feedback we give, we're going to stick to focusing on stuff related to developmental disorders. The landscape has changed now. All the empirical work that we did with patient groups and with the public around the 100,000 Genome Project suggested that people want at least some option, the opportunity to choose to have some feedback. So it seems like it's not sustainable in the same way that it used to be to say we just don't feed anything back. You need to have a policy with a better justification than that if you're going to decide not to feed back. But of course this raises all sorts of problems. If you are going to feed things back, the information is complex, it's often uncertain, and one of the facts about that uncertainty is that may not last forever. So we've got uncertain information now which may become more certain in the future. And there's a lot of information. So one of the questions here is if there is a duty of feedback, whose duty is it, and how do we go about characterising the scope of that duty? And I don't think there's going to be a simple answer. It may be that in pregnancy, for example, there are different obligations than in other areas of medicine, possibly. One of the biggest questions, of course, is what kind of information should be fed back. So should it be clinically relevant information? Should it be information directly related to the disease you're under study? Should you include incidental information if that's clinically relevant? Or should you do what the 100,000 Genome Project does, which is give a list of information and you say to people, would you like this information or not? So it's a manageable list, that's the idea there. In the context of pregnancy, there's a question about when you should feed this information back. So is it reasonable for the researchers on the PAGE project to say we're not going to feed back during pregnancy? Is that a reasonable response, or is that unjustified? I think there's scope for debate there and disagreement. Coming back to the point earlier, is it acceptable to produce information which could be clinically useful but not feed it back? There might be all sorts of arguments which say that's not the case, but there might be some arguments in favour. For example, resources. If you do this, there are certain other things you can't do. And I think resources is actually going to be the biggest ethical issue in genomics in the future. We tend now to focus on findings and so on, but actually I think the uses and the economic sides of resource sides of genomics are actually going to be the big issue in the future. Then there are questions about who should be told. Should it be the woman herself? Should it be the couple? Should it be the child? If it should be the child, when should it be the child? What should happen as they get older? And of course, in this context, there are worries about false positives. And a false positive might mean you give someone some information which leads them to terminate a pregnancy, and 10 years later you find out that that was compatible with a perfectly healthy child. So how do you manage that kind of worry? The background to all of this, and one of the things that's often seen as a kind of a key to achieving ethical practice, is the idea of valid consent. So we've got this idea that consent is expected to do a lot of work. Nonetheless, this is an area where there's a huge amount of ambiguity and complexity, where consent comes under a lot of pressure. So can we expect it to do the work that it has done historically? When we think about valid consent, we usually think of it as having three elements. It should be informed, it should be voluntary, and it should be competent. And pressure can be brought on all three of those under certain circumstances in genomics. Now, one of the things that's really obvious in your area of work is that fully informed consent isn't possible. On numerous occasions now, I've been involved in scientific collaborations where it's apparent that many of the scientists involved don't understand the project as a whole. That's not intended as a criticism. It's intended to reflect the fact that research is increasingly collaborative. So people who understand the disease are not necessarily the people who understand the informatics or understand other elements of the work. So if it's reasonable to accept that scientists don't necessarily understand the project as a whole, clearly it's not realistic to expect patients or participants to understand it. So that means the ethical question is not how can we achieve full understanding. The ethical question is what level of understanding, what kind of understanding do we think is necessary for consent to be valid? And that's a much more pragmatic and reasonable question to ask, I think. So what does good genomic consent or consent in reproductive medicine look like? And I think that's an open question. I'm not sure we know the answer to that yet. Yeah.
I was waiting for answers, but if you say you don't have answers, I'll give them.
No, I'm not saying I don't have answers. What I'm saying is it's apparent in the field that there's not a simple off-the-shelf answer to that. But go ahead.
The answer may be simple. Do we need consent? I really, of course, that's also paternalistic. But I think there's two answers. I think we need to come to consensus. I think in Belgium, for a number of areas, we've done that in the prenatal setting, where amongst all genetic centers, of course, is small. We've made decisions for the community, for ourselves, where we believe as professionals, okay, this is what can be reported, that should be reported, that's what cannot. And there's two levels there. There's indeed a level of healthcare and the support system, which is a very important aspect of it. But if we leave it free to everyone, it's crazy. My uncle, he died just a few months ago, but the week before he died, he had to sign all these consents. He said, I trust people here. I should just say that just one consent, I trust the people. And there's very few people who don't sign the consents, but the number of consents has I mean, I've been submitting grant proposals, so they always have to go through the ethical commission. And just in the last 10 years, the number of consents has exploded to a crazy level where people who enter now the academic hospital, I mean, people go to other hospitals because they're afraid of having to sign all these things. So I think we just go all the way crazy in terms of protecting ourselves, because the idea is then indeed that the individual patients or person who comes into the hospital can decide on all these things. But he doesn't decide anything, to be honest. And I do agree that there should be a level of information, especially if information can come back. That's probably true.
Yeah,
I think we should rethink. And coming from Europe, I think there's an Anglo-Saxon move and pressure onto us, where in the past people trusted their doctors, but in Anglo-Saxon world, probably too. But there's indeed liability. There's lawsuits, especially in the US, probably more than in the UK. And that's where this whole movement came from. And I think we should just stop it. It's taking so much of my time. It's taking so much. I now have more people working with all these consents and things than people doing the lab work. It's becoming a little bit crazy.
So I basically I agree with you.
Thank you.
No, I agree with you. Most of my work, I mean, obviously most of my work has been problematizing the idea of the role of consent. Nonetheless, I do so a good model of genomic consent might be one in which we take the view that under certain circumstances consent is not required. So I do think, I think we'd all agree, for example, if you're going to take a biopsy of endometrial tissue from a woman for no other reason than a research project, it seems to me you ought to ask her permission first. So there are places where we would agree that consent is required, but I think it is complicated. No, I basically agree. Look, my next slide is the limitations of consent, but I basically agree with you. But I do think we need to think carefully about that. Yeah.
I mean, it's nice to talk about all the ethics pros and cons, but what does the law say? I mean, in the end, if you stand in front of the, as a doctor, in front of the GMC or in front of the court, you can say, well, I didn't think it was ethical to do this or that and that. What does the judge say?
Well, you'll find, firstly, it'll depend on the nature of the research, and it'll depend on the country, the country you're working in. So that's, there's clearly. The other, one thing to say is that there are some areas where there's clarity, but there are some areas where you, as researchers or as health professionals, will be required to make your judgment and use your judgment and to present. If you were called to account in court, you'd have to justify your position. So, for example, just to give an example where that's the case, data sharing. The Wellcome Trust and the MRC in the UK and the President's Commission in the US both have policies on data sharing because they perceive there to be a vacuum around some aspects of that. And both their policies say, so for example, the title of the US policy is Anticipate and Communicate. So that policy says you as a scientist have to anticipate the possible kinds of information that you might, this is about feedback. You have to anticipate the kinds of information that you might produce and decide on a policy and communicate that policy at the time of consent. So you'll find that in some areas the law will be very strict. Other areas there won't be any law, but there'll be some guidelines. And in other areas there'll be guidelines like those which are kind of open-ended and require you as a researcher essentially to give an account of yourself to the ethics committee about what you're. So it would be handy if there were. On one account, it would be handy if there were rules off the peg, but in developing areas of medicine like this, for example, I think it's also inevitably the case that the law and guidelines are going to be catching up, and it's really for you as scientists to be saying to yourselves, what do you think, with your patients, of course, and participants, what do you think good practice looks like? So, if you have a specific question, I can tell you what the law says on that, but more often than not, the law is going to leave you space, some discretion for saying what you think is right.
I mean, yours raised an interesting point, particularly in this, this arena where a lot of us are sort of from Europe, and how much of these discussions are happening at a national level and how much is happening sort of at an international level, particularly in sort of genomic studies where we all collaborate with everyone in the world. And, obviously, doing everything according to the ethics that is applicable to a particular country as opposed to. What I mean?
Yeah. There's a lot of complexity. So if you look at the Office of Human Research Protections in the US, for example, they do a survey every year of ethics regulations. So most of my work that's not to do with this is actually in global health. So, and they currently, the last edition of that last year had about 1,500 guidelines that might apply to research in global health. And that's because you've got guidelines in different countries, you've got guidelines about different kinds of research, you've got guidelines about different aspects of research. And what that means is it's very difficult for researchers to decide, firstly, what the right thing to do is, and secondly, it's very difficult for researchers who are collaborating internationally about those kind of things. And there are some guidelines out there, like the CIOMS guidelines and the Helsinki Declaration, but they mostly tend to be fairly open-ended and requiring you to develop an approach that you can. It's complex. And consent is a big issue. If you decide consent is important, which I think we do in some circumstances, all of us, it raises all these issues. Well, how do you achieve good consent? How do you explain complicated concepts to people who are under stress, people who've got other things on their mind, people who, for a whole range of reasons, may not be able to take this information in. So, yeah.
What do you do with historical consent?
Yeah. Well, and how do you and that's an area where you'd expect there to be law, for example, but there isn't much. So there may be in the UK, but for example, in the malaria study I was involved in, and many GWAS studies, how do you? The Wellcome Trust has a call for funding for GWAS studies. You need 5,000 samples or something in order to reach the threshold for funding. Where do you find 5,000 samples? You look around for existing sample collections, and then you look at the consent, and the consent says, genetic research or something, or research in malaria. Well, does that include sequencing? Does that include sequencing? Does it include genotyping? So it raises all these kind of issues. And what happened in that project is I was involved in getting the ethics approval. We got ethics committees to say that the research was compatible with the previous consent, so we didn't have to go and get consent from one again. So that was, yeah.
But also you need to be able to start gaze and look into the future to a certain extent, because I had a session that individuals that were consented even 2-3 years ago, research is accelerating,
Yeah.
we're finding new things, and the interpretation of data and that is already out there will also change over time. So not only, you don't even have to, because data is publicly available.
Yeah.
Somebody in another country where different rules and laws apply and different ethical sort of thoughts are implemented can just analyze the data in a different way, come to different conclusions and interpretations, and suddenly, the data is being used in a way and interpreted in a way that we maybe didn't even think was possible a couple of years ago.
Yeah. So it's interesting, isn't it? So what kind of answer would you want? I guess you want there to be a landscape in which researchers have a sense of what's required to get them to get a project off the ground and to be able to feel confident that it's been thought about. But you also want a living debate about research ethics. You don't want ethics to just be something which is just signed off and put on a shelf. We got through ethics, and we're not going to think about any ethics anymore. So we want a model which, and my approach to this is, you have ethics committees, and they also have a pretty simple one-off kind of structure, set of considerations. But then what you try to do as a funder or as a researcher is you try to embed consideration of ethical issues into the science itself. So you have, my role in the 100,000 Genomes project, but there could be other people where you basically, I'm not the ethics police, but my aim is to try to encourage people to think about practical problems or respond if a problem arises, with the intention of making the science happen. It's not about science. So my view is you have to have a mixed model. You have to avoid the idea that you can deal with everything at the outset. I think that's just unrealistic. So I probably should. I know we're meant to finish at 15:15, so I'll just skim through. So my view is that consent is limited. It's a lot of weight has been put on that since the Second World War primarily, but it's the Nuremberg Code and codes since then have led us to believe, and as you say, an Anglo-Saxon approach perhaps, although the origins of consent are largely in Immanuel Kant, who wasn't Anglo-Saxon, but anyway, have been seen. It's been seen as doing all this work. But my view is it can't do all that work. So the question we should ask ourselves, I think, is what protections need to be put in place so that when someone gives less than perfect consent, they're not going to be discriminated against. They're not going to be identified and kind of be stigmatized in some way. So if we thought about what kind of environment we need in order to make people feel confident and to provide a context in which people can trust, again, health services and research, that's a much more helpful way of thinking about it. And within that context, consent can play an important role, but it doesn't do everything. That's the kind of idea. Do you want me to finish? I'm meant to finish at 15:15, aren't I? So I should probably...
No, but you start with the 10 minutes.
Okay, I've only got a few. Yeah, all right. Sharing data is inevitably going to be an important part of anything that you do. So you're not just dealing with this particular patient, you're dealing with the idea of working as part of a scientific community to encourage the growth of knowledge through sharing information as well as thinking about the person in front of you. So there are lots of good ethical arguments in favour of sharing, but there are lots of concerns about privacy and the potential for unauthorised uses. So one question we need to ask, I think, is a similar kind of question, which is what are the requirements we think they need for ensuring ethical data sharing against a background of trust. I think there are a number of things there. Consent is part of that. We need some kind of oversight of the data sharing so that there is at least someone who looks at applications to use data and says, yeah, that basically seems okay. Is there potentially the need for some way of checking what research activities have been conducted on data that's been shared? So the 100,000 Genome Project, for example, it's taken the approach that research activities need to be done in an environment where it's possible, in theory, to audit those activities so we can say, actually, this person did what they said they were going to do. And that seems particularly important in the context of where commercial companies have access to that data. So you might think that's overkill, or you might think that's not enough. And should we potentially have serious sanctions for data misuse? So the data strategy, which was published by the UK government last week, says that they want to introduce sanctions for deliberate misuse of data and deliberate identification, malicious identification of people. So, that's one possible response to that. We've talked a bit about public trust. I basically agree with you that public trust is important here. Public trust, and particularly the trust of the people who are going to be participants in the research. I think the question of what makes trust happen is an empirical question. I think we did live in a time in the past where people were more trusting of their doctors and have health professionals and medical researchers. I think we live in a world where that's still largely true, but there is a greater degree of mistrust. And I think we need to do some research to find out what's required in order to build trust. And then finally, some slides which are about future uses, future issues, but I still think they're important. So what are the issues arising in relation to the uses of the kind of techniques that we've heard about today, the kind of information that we've heard about today in relation to selection and abortion? So a short-term concern in current practice is this idea that people might use prenatal testing and termination of pregnancy for what, as health professionals, we think of as minor conditions. And we'll obviously disagree about that. And what's a minor condition for you as a health professional might not be a minor condition for a woman who's pregnant and worried about her pregnancy. And so there'll be disagreements about that. But in the longer term, there's the potential for the bringing together of approaches to testing which don't require necessarily the input of a health professional, which could be used to select sex or could be used to select against all sorts of impairments or simply for improved health. So how are we going to manage that? Some people have argued that parents actually have an obligation to have a healthy child if that's possible for them. What do we think about that? We heard a case earlier. We heard someone earlier at the beginning of the day saying, why wouldn't you choose these embryos? Why wouldn't you choose these embryos if they're more likely to lead to a healthy child? But that seems like a reasonable thing to make. But does that take us all the way to saying that we should be testing pregnancies? And there are lots of arguments against selection. Some of those, I'm using selection as opposed to abortion. Clearly there are lots of arguments about abortion, but there are arguments about selection too, from various quarters, from disability rights groups, for example, and from views about discrimination, views about overly narrow conceptions of what a good life looks like. And of course, these things also apply to gene editing and the potential for interventions which are pre-conception. So we've talked today largely about interventions following conception, but what about interventions in at the egg or the sperm stages? Commercialization is obviously clearly an issue. certainly in the space of non-invasive prenatal diagnosis. I spoke at the Prenatal Diagnosis Conference in Berlin earlier last year, and it was striking how many commercial companies were involved in that meeting. It's clearly a space where commercialization is going to be an issue, as it is in many of the other areas you speak in. So some of those issues are worries about commercialization and exploitation. Some of those are worries about the possibility of people getting tests without going through health professionals, and whether we think that's how that should be managed. And then finally, just one of the thoughts I had today, we're listening to someone speaking earlier, was if we do take this view that the environment during pregnancy is going to have increasingly to be seen as having implications for the future health of children, in situations where there's a potential to do something about that, let's say, for example, it relates to obesity or relates to some other condition which might be treated or might be ameliorated over time, is this likely to lead to a context in which women are increasingly going to come under some kind of moral scrutiny? So, for example, should I wait a couple of years before getting pregnant whilst I reduce my weight or get my condition under control? So there's the potential here for those kind of considerations, and I think. And of course, from a philosophical point of view, an important point to make, it's not only a philosophical point, but it's also a medical point, which is delaying a pregnancy doesn't make the same pregnancy healthier, it makes it a different pregnancy. So, a particular pregnancy can only come into existence as that particular pregnancy. So there's often a rhetoric around these kind of things, which is the baby would be healthier if you waited a year to have it. Well, that's obviously not the case, because it's a different child.
I was going to say, I don't think that's a future implication for anyone who's being pregnant to go to the midwives, no matter if you're in the US or the UK.
Yeah.
If you wait and you have to discuss your age all the time and so forth.
Yeah.
So I think it's already ongoing that you're seen to have a responsibility
Yeah.
to not burden.
But that struck me as being, if the evidence that was presented this morning and the suggestion that that's going to be a much more an area of fruitful research, if that's the case, potentially it has these implications, I think.
Following on from that, I mean, aside from women have responsibility, surely that already exists, as you said, but it's how is it going to then transfer to actually being legislated to have an effect? I mean, I walk into hospital every day, apart from when you're pregnant and smoking, and I'm just sitting there going, when is it? Isn't it almost effective child abuse? When's it going to swap from one to the other, or is it?
Yeah, and I think there's a lot of debate about that in a whole range of areas of medicine, to do with liver transplants, and there's a whole range of areas where responsibility for our own health is an issue for debate. And I think people will differ in their views about that, not only as a general kind of concept, but also in particular areas where clearly there are some situations in which people have there are lifestyle factors that affect their health, but they don't necessarily have much control over their environment. So there's going to be a whole range of different ways. So it seems likely that that's going to increasingly become a debate in certainly in the UK, and I imagine elsewhere. I like the idea that we're not Europeans anymore, by the way. Some of us are for the time being. Okay, so I think I'll stop there. But I think the message I would want you to go away with, apart from the fact that there's a lot of complexity here, is that you as scientists can have a role to play in what reproductive ethics looks like. It's not simply something for lawyers, ethicists, and others. That if you as a community come to a view about what would be acceptable research practices in your area, I think that can have some influence. So, for example, tomorrow morning I'm giving evidence at the UK Government Science and Technology Select Committee, and I'm giving evidence along with some scientists about what good practice in genomics ought to look like. So there are potentially opportunities for people to say, and I think if you publish in particular collective views about what good practice looks like, then maybe you can have some influence about the future. So I'll stop there.